Hello everyone and welcome to My Spine World. Have you ever had difficulty in reading an MRI scan? This talk will help you to read an MRI in 5 easy steps. The purpose of this talk is not to go into the physics of how you do an MRI, but how to interpret it. In this talk, I will be talking about standard sequences in an MRI. We'll be going through cervical spine anatomy, steps of reading a cervical spine MRI. Then we will be talking about lumbar spine anatomy. Then go on to steps of reading a lumbar spine MRI. There are 3 basic planes that you should know before you interpret an MRI. One is a sagittal plane. Next would be an axial plane. And then on your extreme right would be a coronal plane. There are certain standard sequences that you should know before you read an MRI. These are the T1 weighted images, axial and sagittal, the T2 weighted, which is axial and sagittal, the STIR or the T2 fat suppressed image or the TRIM image. And sometimes you have contrast injected, and hence you have a T1 post-contrast MRI. There are a multitude of sequences depending on the purpose and the location of how you want to do an MRI. But for cervical and lumbar spine, T1, T2, STIR image, and sometimes post-contrast image are the usual standard sequences. An MRI sequence is a particular set of pulse sequence or a pulse field gradients that result in a set of images with a particular appearance. It can be hyperintense, which means brighter than the thing that we are comparing, or hypointense, which is darker than the thing we are comparing. So what is what? Usually the standard sequences are the T1 and the T2 weighted images. And here, as you can see, fat in T1 and T2 appears hyperintense or bright. Water appears hypointense or dark in T1 and hyperintense or bright in T2. Whereas bone appears hypointense in both T1 and T2, and the fibrous tissue also appears hypointense in both T1 and T2. So as you can see, the main difference is how fluid or water appears in T1 and T2. So in T2, water is bright. So signal intensities in MRI, as you can see, fat is bright in both T1 and T2, and fluid or water appears dark in T1 and bright in T2. Now let's go on to some MRI pictures to have a look at both the T1 and T2 images. So here's an example of a sagittal image of a lumbar spine MRI with a T1 and a T2 weighted images. As you can see, in T1, your fluid or your CSF appears dark. In T2, the fluid appears bright. And in T1, the subcutaneous fat, which is shown here, is bright or hyperintense, and in T2 it is hyperintense as well. So the main difference here is the fluid, which is dark here in T1 and bright here in T2. Now let's see some axial images for T1 and T2. So on your left side is a T2 image. As you can see in the axial image, the CSF here is bright or hyperintense, and the CSF here is hypointense or dark. And the fat, the subcutaneous fat, is bright in both T2 as well as T1. So once you have understood the basic differences between T1 and T2, let's go on to assess what a fat suppressed image or a TIRM image shows. So here's a sagittal section of the lumbar spine MRI in T2, T1, and a TIRM weighted images. So you can see in T2, the fluid is bright. In T1, the fluid is dark. Whereas TARM, the fluid is bright as well. So you might ask, what is the difference between a T2 and TARM? Well, the difference is where you look at the fat. In T2, the fat is bright. In TIRM, the fat is suppressed. In other words, TIRM picks up only the fluid, which is usually helpful when you are looking at an acute fracture, when there's an infection, or sometimes even a tumor. TARM means turbo inversion recovery with magnitude display. It is superior in assessment of osteomyelitis, tumors, or sometimes even acute fractures can be picked up on TIRM images or a fat suppressed image. Let me explain how. So here is an example of a sagittal image of a T2 weighted image on your left and a TIRM image on your right. The pathology that is shown is an L1 fracture, which is not so clear on T2, but whereas in TIRM, you can see that the signal change is quite bright here, which indicates that there is an acute fracture in this vertebra. You can also see the fluid or the bright image or hypointense image in the subcutaneous tissue, which can tell you even some more, saying that this particular patient probably has had an injury to the back with a fall, with a contusion of the lower back, and also a fracture on this particular vertebra. In fact, a lumbar 2 vertebra. Now let's assess what is a contrast image. A contrast image here is shown of a sagittal section of T2, TRM, as well as a contrast image. And the pathology that we are talking about is the vertebra on lumbar 4. You can see that there is a collapse of the vertebra here on the sagittal view, which probably with a complete signal change in the whole of the vertebral body, meaning that there is a possibility of a pathological fracture. So when you compare of TIRM image with a T2, you still cannot make out whether there is an epidural component or not. Whereas when you compare the contrast, you can actually see that the contrast lights up, which possibly means there is a pathology there in the lumbar 4 vertebra with a canal compromise, which is more clear in a contrast image. So the question you ask is, when do you do a contrast? Contrast is usually done when you are assessing a patient who had a previous surgery within the less than 6 months, when you're suspecting an infection, when you're suspecting a tumor, and sometimes in case of demyelinating diseases. Let's go on to assess how we are going to read this MRI. What are the basic steps in reading an MRI? So usually the steps that I follow, first you need to look at what are the sequences that you have for review, whether it's T1, T2, TRM, or whether it's a contrast image. Then first I look at the T2 weighted images first. That will give you a pretty good idea of what the pathology is and give you a perspective of things. Then I look at the T1 weighted images, which is more for anatomical details. Then I look at the TIRM image, or the turbo inversion recovery with magnitude display. It is actually superior in assessing whether a pathology that you're looking at is fresh, whether it's an infection, whether it's a possibility of tumor. Then I look at various specialized MRI pulse sequences. Could be a contrast image in this case. And then I go on to look at the scout images, usually for lumbar spine or sometimes even for cervical spine. The radiologist will give you a scout image, which actually gives you a whole sequence of your whole spine and can tell you whether there is a pathology that you are missing, either for a cervical spine when you're doing a lumbar spine MRI or a thoracic spine when you're doing a lumbar spine MRI. And the most important, that I looked at the report, whether I've missed something. The radiologist can actually report various coincidental findings like thyroid nodules or sometimes even uterine fibroid, which the report usually mentions. And then the most important step, which is the 8th step of this, is actually how you correlate with the clinical findings of this patient. Now you know the basic steps of interpreting an MRI, either it be lumbar, cervical, or thoracic, or a whole spine MRI. Let's go on to see what are the basic steps when you actually are sitting in front of an MRI. How I do it is in 5 easy steps. It is as simple as A, B, C, D, and E. So let's see what are these steps. A is the alignment, B is bone, C is for cord or canal, D is for discs, and E is everything else. I will go through each after I go through some of the anatomy of the cervical spine. So we will be starting with an interpretation of a cervical spine MRI. So first I'll go through some basic anatomy. The cervical spine, as you know, the C1 and C2, as shown here, this is the C1 vertebrae. You know there is an anterior arch, anterior tubercle. Then you have the posterior arch and posterior tubercle. So this is the superior view of the C1 vertebra or the atlas. And you can see the joint here with the transverse process there, the transverse foramen where your vertebral artery traverses. And this is the inferior view showing the posterior arch, the posterior tubercle, anterior arch, anterior tubercle. And then on to the right side of the screen is your C2 vertebra, which is your axis with the special dens and the anterior articular facet to articulate with the posterior part of the anterior arch of atlas. Then you have your inferior articular facet, which articulates with the C3, and your superior articular facet, which articulates with the atlas. And this is the posterior-superior view showing the C2 vertebra. And the last part is where how all the vertebrae C1, C2 looks when it articulates with each other. Now let's go on to see what are the ligaments between C1 and C2, which holds everything together. So this is actually an anatomical or section which shows you the ligaments between C1 and C2. So you can make out your transverse ligament here, the alar ligament, then you have the apical ligament, and in your sagittal section here you can see your atlanto-occipital membrane, the apical ligament of the dens, then you have the tectorial membrane here, then you have the transverse ligament, which is a cut section here. Then of course you have your anterior and your posterior longitudinal ligament. Now let's see what is the subaxial vertebrae looks like. So here is an example of a 4th cervical vertebra. So you can see there is a body there. There's an anterior tubercle, posterior tubercle, transverse foramen, which transmits the vertebral artery. Then of course you have the lamina here, and then your spinous process, which sometimes is bifid, usually for cervical 2. And then you have the 7th cervical vertebra, which of course has got this long spinous process here. Then you have the posterior and the anterior tubercle, and then you have your articular facets. And here's how it actually looks in a sagittal or a side view after articulation. And you can see your lateral mass here with the superior and the inferior facets and the neural foramen. And this is the anteroposterior view where you can actually appreciate your uncus as well as the uncovertebral joints between C3 and C4 here. So you can see that all these are well aligned. So in this section, it actually shows you the side view where with the soft tissue structures included. So you can make out your disc between C2 and C3 here, Then you have the nerve roots, which is exiting. So that's the neuroforamen there. You can appreciate the vertebral artery, which is actually traversing the transverse foramen there. And this is a relation between the C1 and C2, which is a cut section. So you can see the ADI, or atlanto-dense interval, which is this small gap here, which is usually around 4 to 5, usually less than 3. And then here, which is actually the space available for the cord behind. And here is the articulation between C1 and C2. Normally, it completely overlaps in an anteroposterior section. And this is a view that you get when you do an open mouth view for an X-ray. You can see if the overlap or the not overlap part, if it is more than 7 or 6.9, then you know there is a C1, C2 instability. You all know how an alignment looks in a standard radiograph, which is how you interpret. Normally, there is A1, A2, A3, B, or C. This is how I used to learn. A is whether it's appropriate, whether it's correct indication. A2 is whether it's adequate. A3 is alignment, whether you have anterior, posterior, spinal laminar line, tips of transverse spinous processes. And then B, we look for the bones, and C, we look for the connective tissues. When you read an MRI, it's pretty much similar, maybe with slight differences. Now let's go on to see how is an ABCDE going to pan out for interpreting an MRI or how reading an MRI. So like I told you before, the steps are A, B, C, D, and E, 5 steps. A, as I told you before, is for alignment. B is for bone. C is for cord or canal. D is for disc, and E is for everything else. When you look at alignment, like you read a standard radiograph, you have the A is your anterior portion of the vertebral body. B is the posterior portion of the vertebral body. Then you look at the facets. Then you look at the posterior spinal canal line. Then you look at the spinous process line. You can see that all these would be aligned in a standard radiograph. So for example, here you can see there is an atypical Hangman's fracture. That means there is a C2 body fracture with the anteroposterior displacement of the fracture fragment. And the fracture disrupts the Harris's ring posteriorly and causes a posterior offset of your spinal laminar line. This is just a radiograph to actually tell you that alignment sometimes can be very subtle and is important. And here, it is pretty much obvious that your alignment is off. And this is actually an example of a bilateral facetal dislocation, how it looks. You can see that 2, 3, 4, 5, between 5 and 6, there is an anterior listhesis, which is more than 50%, which actually tells you there is a facetal disruption, and it's most possibly a bilateral facetal dislocation. Same things that you can see on an MRI as well. You can see that the alignment here is off. So that is what A means. You look at the alignment, whether it is off. Sometimes it's obvious, sometimes it's very subtle. Now we go on to B. B, like I told you before, is for bone. What are you looking for? Sometimes you're looking for fractures. Sometimes it could be a burst fracture. Sometimes it could be just a vertebral body compression. Or sometimes even a blastic or lesions inside the bone can also be picked up as signal changes in an MRI. Fractures sometimes can be a compression or can be a burst when your both columns are involved. It can be a translation or rotational injury or a distraction, which is more severe injuries. For example, here, this is a CT scan on your left side, which actually shows you very subtle fractures and a corresponding MRI. These are very subtle fractures. And here, of course, you can see that there is a fracture with distraction or even a translation with a quite severe significant canal compromise. You can see that both A and B are disrupted here. Alignment is gone, as well as B, which is your fracture in the bone. So these are sagittal images. Now let's look at some of the axial images. So these are corresponding images from a CT scan, which is showing a burst fracture. And this is actually from a lumbar, but you can still make out the difference of how you want to interpret an MRI with regards to bone or B. And here is again sagittal image showing a fracture, and here on the corresponding MRI, which shows a fracture of this particular vertebra. So that's B is for bone. Now let's look at, apart from fractures, what else can B or a bone signify? So here is a sagittal T1 weighted MR, which shows patchy hypointense replacement of the fatty bone marrow. both in the cervical and the thoracic spine, with the disc still appearing brighter than the adjacent marrow. Now, these are very typical of diffuse metastasis. So, when you interpret B, you should look at not just for fractures, but these signal changes as well, which can actually tell you that there is some pathology going on. Let's look at the next, which is C, which is for cord or canal. What are the pathologies they're looking at? Either it could be a cord compression, could be extra or intramedullary, could be canal hematoma, stenosis, which is the most common, and neuroforaminal stenosis. Now, canal stenosis or neuroforaminal stenosis are usually because of a herniated disc or a bulging disc, bone spurs or osteophytes, spondylolisthesis, which sometimes also can result in a pseudodisc perhaps, then sometimes facetal diseases, or a degenerative disc disease. For example, here you can see that there is a canal compromise here, which is caused by a compression both from the front as well as from the back. So this is a disc osteophyte complex, which is actually resulting in a cervical spine canal compromise. And you can also see there is a signal change within the spinal cord, which is a myelomalacia change, signifying that this could be a cervical myelopathy. And this is the corresponding axial images for the same. Now let's look at D, which is disc. You can look at the disc height loss, disc bulge, or a protrusion. In this sagittal image of the cervical spine MRI, you can see this two-level disc bulge or a disc prolapse between 2, 3, 4 and 5 and 5 and 6, causing some amount of canal compromise. And then E is for everything else. You look at the paraspinal soft tissues, whether any signal changes there. Sometimes even thyroid, you might not be able to pick it up, but definitely the radiologist would report if there's a thyroid nodule that they have noticed. You can even look at the aorta, or sometimes even in a trauma situation, you can even read like a pneumothorax, which is shown on these MRIs. Sometimes you can see there's a sternal fracture. It's actually a CT scan which is showing a sternal fracture, and here you can see a hemopneumothorax. So don't forget to look at other soft tissue that is available for viewing at the end of you interpreting a spine MRI. So that actually concludes of how you interpret a cervical spine MRI. So basically you go through 5 easy steps, which is A, B, C, D, and E. A is for alignment. B is for bone. You look at either fractures or you look at some signal changes, which can signify either an infection or sometimes even a tumor. C is for cord or canal. D is for disc, and E is for everything else. Now let's go on to interpret a lumbar spine MRI. But before I go into that, let me go through some of the anatomy of the lumbar spine. So here I'm going to go through a sagittal image of a lumbar spine MRI, as well as some of the anatomical structures which is shown on the slide on the right side. So here you can see these blocks are your vertebra here, which is your 5, 4, 3, 2, and 1. And the one which is highlighted in red here, that's your disc. And then you can see the spinal canal here. You can see the nerve roots. Usually the spinal cord ends at the lower border of T12 or L1. And then you have the chorda equina rootlets coming down. And then this is your mid-sagittal cut on your left side. And figure 3 is your parasagittal cut, which can actually show you can even see the nerve rootlets of the chorda equina coming anteriorly to exit near the neuroforamen there. And this is your typical lumbar vertebra, which is your big body there. Then you have the pedicle here. Then you have your transverse process. Then you have the facetal articulation here. Then you have the lamina here. And then you have the spinous process. And that's your typical intervertebral disc with your nucleus pulposus and your annulus fibrosus. And this is how it looks when it articulates with each other. So you can see your body here, the pedicle here. Then you have your articulating process there, the transverse process, spinous process, and then you have facet joint here, and then you have the neuroforamen here. Right, let's go on to look at the MRI images. So this is actually a disc prolapse between lumbar 4 and lumbar 5 in your parasagittal cut, which is more clear. And you can even see it is actually indenting on one of the nerve roots, which is usually the traversing nerve root, which is your lumbar 5 nerve root. And this is your foraminal cut, which actually tells you the exit foramen of this particular level. And here you can see, and if you correspond it to this schematic diagram here, so that's your exit foramen, and you can see the nerve root is actually on the superior aspect of the foramen. You can even see it is like a pear shape, which is narrow on the inferior aspect, wider on the superior aspect, and you can typically see the nerve root, which is the exiting nerve root there. And these are the facet joints. P is your pedicle, and this is your spinous process. So there's so many details when you look at it, you can actually see on an MRI. It's just you should know the anatomy first, and you should know where to look for it at different cuts. So here again, the foraminal cut, we actually see your foramen and your nerve root, which is on the superior aspect of it. You can see some narrowing of the foramen here. Now let's look at the axial images. What are the things that you need to know in an axial image? So this is a typical image which is taken at the disc level between lumbar 4 and lumbar 5. And this is what you see. So in here is your disc, which is your 4 and 5. And then this is your thecal sac, which is highlighted in green. Highlighted in red is your neuroforamen or the neuroforamen area. And this is your facet joint. And usually they mention whether it's right or left. So this is the right here and the left here. This is your posterior arch, this is the lamina here, and the spinous process. And you can even see the paraspinal muscles at the back of on the side of the lamina, as well as the spinous process. And so this here is a diagrammatic representation, annular fibrosis, nucleus pulposus, and similarly, you can see your thecal sac here with the nerve rootlets. So if you're looking at a 4 and 5, L5 is your traversing root, L4 is your exiting root, and you can see the dorsal DRG or the dorsal root ganglion. This is your transverse process here. And when you look at the facet joint at this particular section, it is like a hamburger. So this aspect of the hamburger is actually the SAP or the superior articular process. And behind is your inferior articular process. And here you can see the lateral recess, and your neural foramen. So you can see the central canal. So if there is a compromise here, it is a central canal stenosis. If you're compromising here, that is your lateral recess stenosis, and here would be your foraminal stenosis. Now, as you know how axial section looks on a lumbar spine MRI, let's go on to correlate between sagittal as well as an axial image. So here's an example of a cut section between lumbar 4 and lumbar 5, and this is how typically it looks in figure 7. So this is your lumbar 4, lumbar 5 disc, and here would be your exiting nerve root. You can actually sort of see it, that black strand there. That is your L4, lumbar 4 exiting nerve root, and that's your neural foramen there, where your lumbar 4 exiting nerve root exits. And here, this black dot there, that is your traversing lumbar 5 nerve roots. And you can see the other sacral nerve roots on the posterior aspect of it. And here would be a pars, and then that would be a facet joint. And here, like I told you before, that would be a superior or articular process, or a SAP. That's your facet joint there, and that's your inferior articular process. And here is your lamina, spinous process, and the paraspinal muscles. Again, let's go on to the steps of interpreting a lumbar spine MRI. Like I told you, 5 easy steps: A, B, C, D, and E. A is for alignment, B is for bone, C is for canal or cord. There's no cord in the lumbar spine, and so it'll be the canal. D is for disc, and E is for everything else. Let's go and look at the A first. So A is for alignment. So you can see on the section on the left of the sagittal image there, the vertebrae are well aligned from L1 to L5 and even to S1. Whereas a sagittal image on the right side, MRI actually shows there is some misalignment, especially between lumbar 5 and sacrum 1 vertebrae. So this is actually an MRI of a grade 2 spondylolisthesis But what you need to pick up from here is that there is some misalignment there. And because of that, there is some canal compromise at L5-S1 level. Bone. B is for bone. Well, here you can clearly see between 5, 4, 3, 2, 1, all the vertebrae here are fractured. So the bone, there is a fracture there, which is corresponding here, which actually shows you a burst fracture of the lumbar 3 vertebra with a retropulse fragment causing severe canal compromise. I told you before, it's not just fractures. Signal changes in the bone can indicate something more sinister. For example, here, you can see there is a fracture, 5432, 5432 in the lumbar 2 vertebra here. And you can see the signal is definitely it's quite different from the other corresponding vertebrae above and below. And it is causing a canal compromise. And this image, which is a T1 image, actually shows you also a signal change, which possibly means there could be a pathological fracture of this particular vertebra. And here you can see the typical signal changes that you can see in multiple level of bones. And you can see these also shows some shadow in the front with some fluid signals there, which is possibly means there could be a disseminated TB in multiple levels with abscess tracking along the anterior longitudinal ligament. So B, or the bone, signal intensities can tell you other diagnoses as well, whether it could be a pathological fracture, whether it's an osteomyelitis, or whether it's something else. Next, we go on to C, which is for cord or canal. C is for cord or canal. And now there's no spinal cord in the lumbar spine region, so it's mainly a canal compromise. So it could be at a cord compression or cord equina compression, could be extra intramedullary or a hematoma, or stenosis, either it's a central or neuroforaminal stenosis, which is more common. Let me show you an example of how things can sometimes easily be missed when you don't go through these sequences. So see, I told you it's for cord or canal. Now, this is actually MRI or sagittal section of a thoracic spine. And you can see there's a subtle difference here. There is something which is occupying the canal, which is possibly a tumor, which is an intradural tumor, which is on the thoracic 1, 2, 3, thoracic 4 level, right? And this is a T1 image, which actually shows you more delineated image there. And this is the TRM image, which actually brightens up there. So if you don't go through these sequences, sometimes you can miss these findings because the rest of the bone actually looks normal. The alignment looks normal, bone looks normal, canal not so much compromised, but it is actually the cord which is showing some changes here. Now let's go through these sequences one by one. So here's an example of sagittal section of the lumbar spine MRI, as well as the corresponding axial section on the right side. So here's a cut section between lumbar 2, lumbar 3 disc. And you can see on the axial section, so this is the lumbar 2, lumbar 3 disc here. And here will be the central canal. Here will be the lateral recess, and here will be the foramen. And you can see the neural elements there. And here you can see the facet joint. And this structure here, like the hamburger here on top, would be the SAP, or the superior articular process. And then the inferior articular process here. Then you have the lamina here, the spinous process here, as well as you can see the paraspinal muscles here. You can even make out the psoas muscle on the side of the disc, and then the vertebral body. So here at this level, there is not much canal compromise, either in the central, lateral, or even the foraminal area. Below, so you can see there is listhesis here between 4 and 5. So you know the alignment is off there. There is some canal compromise at that particular level, and you can see that the central, lateral, as well as the foraminal canal is compromised. There is a stenosis, which is quite obvious on the axial section, right? So this is just to explain how things, or how canals can get compromised when you have a disc collapse. So here is, for example, say this is between 4 and 5, and here you have the bone here, you have the disc here, and you have the exiting nerve root there. So when you have the disc collapse here, you can see that this is a superior articular process. You can see how the superior articular process encroaches onto the neuroforamen there, causing impingement of this particular nerve root. Quite significant. And this is what you see on an MRI. For example, here you can see this is a foraminal section here of the same patient between 4 and 5. You can see on the top level, you can see the neural foramen, which is pretty much open. You can see the white signals of the CSF, which is there. And here there's complete effacement of the CSF, and there's not much canal seen, which you can see that this is 5-4. You can see that the lumbar 4 nerve root, which is the exiting nerve root, would be impinged here. You can see some encroachment in the lower level as well. Let's look at the midsection. Well, there is some central canal stenosis, but not so bad between 4-5 listhesis. And when you look at the opposite side foramen, which is your left side, you can see that again the canal is compromised. Now let's go on to look at D, which is for disc. Well, it could be a bulge, could be a protrusion, could be an extrusion, or could be a sequestration. And that's the definition that I've shown you on the slide there. Well, you can pretty much interpret whichever way you want according to this definition, but this is what you should look at when you look at the disc. It could be a disc protrusion, or it could be even a signal change in the disc, which can indicate it could be a discitis. For example, here, when you look at, say, between lumbar 5 and sacrum 1, there is, you can see there is a disc prolapse, which not so clear because this is a mid-sagittal section that you see. And actually, it is a paracentral disc protrusion. So when you click the site to the parasagittal section, you can see that this is more prominent. So you can see that onto your left side, between 5 and 1, there is a disc prolapse, which is touching on probably the traversing nerve root. And maybe your exiting is also partly compromised or impinged. So once you've done the reading of the lumbar spine MRI in terms of alignment, bone, and canal compromise, it's also a good idea at this point that I can describe to you what are modic changes. Sometimes you will see these modic changes being reported by the radiologist. So there are mainly 3 types of modic changes, which for easy purpose is being described, which is 1, 2, and 3. And the difference is how it appears between T1 and T2. So these changes appears on the vertebral body, especially near the end plates. So modic 1 basically means there is hypointense in T1 and hyperintense in T2, which indicates edema. Modic 2 means hyperintense on T1 and hyperintense also on T2, which is fatty degeneration. And modic 3 means hypointense both in T1 and T2, which means a bony sclerosis. So here you can see modic changes between lumbar 4 and lumbar 5. You can see it is hypointense on T1, which is dark, and hyperintense, which is more fluid-like on T2, which indicates there is edema. So there is edema changes here between 4 and 5. Let's look at the modic type 2, which is your between L5 and S1. You can see it is hyperintense or bright on T1 and bright on T2, which indicates there is a fatty degeneration. Then, which is modic type 3, again, you look at between 4 and 5, is hypointense in both T1 as well as T2, which indicates there is a bony sclerosis. These modic changes help you interpret whether there's instability, whether there's any fluid there, which can indicate possible infection. But it can help you and also help you interpret the MRI report as well. Let's look at the final part of your step of reading an MRI, which is your E. So now we have come to E, which is for everything else. So if you look at the sagittal section here of the lumbar spine MRI, you know that the alignment looks okay, the bone looks all right, but there's something else that you could miss. So on the axial section here, you can see that there is some signal change that is happening on the right side paraspinal musculature. At the same time, you can see there's some fluid inside your facet joint at this particular level. The left side is okay, but the right side, there is some fluid signal, which could mean that it could be a septic arthritis with an associated abscess in the paraspinal area. Even in the sagittal section, you can see this encapsulated abscess, which is present in the paraspinal region. So before you conclude reading an MRI, look at the soft tissues. It could be paraspinal muscles, or it can even would be psoas. Sometimes even psoas abscess can be picked up on these MRIs. Now we have come to the end of the presentation. Hope this presentation was useful to you and will help you in reading MRI, either for lumbar or a cervical spine. Do spread the word and please do share with anyone who is keen. For further articles, visit my website and follow me on LinkedIn and Facebook and click on the links given. Thank you so much and see you soon with another video. Bye and stay safe.